Hello. In this topic, I'll talk about inotropes and vasopressors, which are mostly your sympathomimetic drugs. So, sympathomimetic drugs, what is unique about them? Now, sympathomimetic drugs, they are different. The huge group of drugs. There are different type of drugs, and in most of the drug, there is a slight change in the structure. I mean, there is a difference in the substitution of the amine group in the structure, and this slight change only influences how they attached, what is their affinity for two type of important sympathetic adrenergic receptor, that is alpha and beta adrenergic receptor, right? So just a little bit chemical structure has been changed, and the drug's sensitivity for alpha and beta receptor changes. And not only the drug's sensitivity for alpha and beta receptor, the effect also depends upon how the alpha and beta receptors are distributed throughout the organs and what is the density of alpha and beta receptors on different organs. So drugs which would influence alpha and beta receptors when they are given, the effect depends upon the distribution of alpha and beta receptors on different organs and density of these receptors on these organs. That also affects the final response. So the result of the effect of these agents are very complex, right? Some will have alpha predominant effect, some will have beta predominant effect. The drugs which will have alpha predominant effect, they would be mostly used as vasopressor, and drugs which would have a beta predominant effect, they would mainly be used as inotropes, and some drugs have effects both equally good on both the receptor. So kind of complex interaction, the overall results takes place. There are very important few drugs which we need to discuss in this topic, and I will discuss those drugs. Okay, so first of all, first thing I want to tell you that your adrenergic receptors are divided into two types. I mean, rather I would say three types: alpha, beta and dopamine receptors, right? Alpha, beta and dopamine receptor, or DA receptor we will write it. Alpha is further divided into alpha 1 and alpha 2, and beta is further divided into beta 1 and beta 2, and dopamine in dopamine 1 and dopamine 2. Okay, so all the drugs which I will discuss, the drugs would produce the effect due to interaction on these 6 important receptors, right, which we have to know about. So how I will tell you about these drugs? First, I will tell you when these receptors are affected, what is the response which we will get. That is, where are these receptors distributed? So distribution, their distribution in the different organs, and response, what response we will get on their stimulation, right? So let us start with alpha 1 adrenergic receptor. Alpha 1 adrenergic receptor, or let's say alpha 1 alpha 2 adrenergic receptor. Now both alpha 1 and alpha 2 adrenergic receptors, they are present on the smooth muscles. They are mostly present on the ligand where they bind. It's present on the smooth muscle of the vasculature which innervates different organs, which is present in the different organs. So it is innervating the smooth muscle vasculature of the different organs, and the effect is as a result of the, let's say, increasing or decreasing tone of those vasculature. See, alpha 1 receptor is mostly present. It is mostly present on post-synaptic smooth muscle cells of peripheral vascular system. Peripheral vascular system of different organs, right? And when they are stimulated, they can increase or decrease the tone of these peripheral vascular system. And when increase in the tone will happen, then vasoconstriction will happen, and when decrease in the tone will happen, vasodilatation will happen. So depending upon that what is their effect on the peripheral vasculature, we will get the effect and we will discuss on which organ they increase the tone of the peripheral vasculature, in which organ they decrease the tone, right? Then alpha 1 adrenergic receptor, it is basically of two types, presynaptic and postsynaptic. Presynaptic and postsynaptic. Okay, so postsynaptic alpha 2 also more or less it also innervates the smooth muscles of the peripheral vascular system and produces the effect. Presynaptic is used for modulation of norepinephrine release. It modulates the norepinephrine transmission. Okay, so it modulates the norepinephrine transmission. This presynaptic receptor, it was discovered, and because of the discovery of the presynaptic receptor only, the alpha 1, alpha 2, the alpha receptor, adrenergic receptor was divided into alpha 1 and alpha 2, right? Alpha 1 is present on the presynaptic part of the synapse, and because of the presynaptic effect, it modulates the norepinephrine release, whether it can increase or decrease the norepinephrine release. We will see what alpha do. Beta also has a presynaptic receptor which also modulates the norepinephrine release. So let us talk, how does first alpha receptor act? What is the molecular level? How does they act? So this diagram, so whenever an alpha agonist attaches to the alpha receptor present on the cell membrane of the vasculature, it is present on the cell membrane of the vasculature, right? GQ protein is activated, and it activates few important neurotransmitters like ionostiol, triphosphates. What does these do? They increase the cytosolic calcium. They increase the calcium, right, inside the cell membrane, and this increase in calcium this stimulates the calmodulin dependent protein kinase, and this would cause vasoconstriction. So it would increase the tone, it would cause vasoconstriction. So alpha agonist, they stimulate the tone of the peripheral vasculature by increasing the cytosolic calcium. So number of times in calcium deficiency, their effect may not be optimum. So we need to have a proper calcium, let's say serum calcium level for their optimum effect, right? So they cause vasoconstriction. Now let us see where are these receptors distributed and what is the effect of stimulation of these receptors. So alpha 1 receptor, I told you it is present mostly on postsynaptic site, right? Postsynaptic site. And the anatomic site where it is present, with the organs where it is present, is peripheral vascular smooth muscles throughout the body, peripheral vascular smooth muscles, renal vascular smooth muscles, coronary arteries, and myocardium, heart myocardium, and on renal tubules, okay? And if it attaches to the peripheral vascular smooth muscle, it causes constriction, renal vascular smooth muscle constriction, and coronary arteries constriction. And on heart, when it stimulates the alpha 1 receptor present on the myocardium on heart, then it would cause stimulation, that is positive inotropic effect, inotropism, okay? And on effect on the renal tubule, it will cause antidiuresis. Antidiuresis will decrease the urine formation. Alpha 2, I told you, is present on presynaptic peripheral vascular smooth muscle, the presynaptic part. It inhibits the norepinephrine release. It decreases the noradrenaline release, okay? And on coronaries, it is present on coronary arteries. It causes secondary vasodilatation. In CNS, it is present the alpha 2 presynaptic, right? Alpha 2 presynaptic agonist, the dexmedetomidine and clonidine, they are the agonist. So they are present on the CNS, these receptors present on CNS, and it causes sedation. So we know very well that dexmedetomidine and clonidine, which are kind of pure alpha 2 agonist, they can cause sedation by having the effect on the presynaptic alpha 2 receptor present in central nervous system. Okay, then postsynaptic, it is mostly present on coronaries, endocardial, and central nervous system, right? In coronary artery, on heart, endocardial system, and mostly it causes constriction, right? It causes constriction and decreases the coronary blood flow. And on CNS it is present. So on CNS it produces multiple effect, like it decreases the insulin release, it decreases the bowel motility, inhibition of antidiuretic hormone release, and analgesia to some extent. And on renal tubules it is present, the postsynaptic alpha 2 receptor, and it promotes the sodium and water excretion. So it promotes the excretion. Okay. So alpha 1 and alpha 2 receptors, as I discussed, they are present on following anatomical sites. Now let us talk about the beta receptor. The beta receptor. Again, I told you the beta is divided into the postsynaptic and presynaptic. Presynaptic. Now postsynaptic is mostly beta 1 and beta 2, both presynaptic and also postsynaptic. So beta 2 both presynaptic and postsynaptic sites is present on the synapse sites. Okay. How does when beta agonist attaches to the beta receptor present on the cell membrane, how does it act? What is the molecular mechanism? So again, it modulates the guanosine GTP, adenylate cyclase, and it causes activation of cyclic adenosine monophosphate release. It causes adenosine monophosphate release, and this results in calcium channel activation. And when the calcium channel is activated, the cytosolic calcium increases, and because of actin myosin, because of increased calcium, a positive inotropy effect is seen in the cardiac musculature. And because of increase in cytosolic calcium, again positive chronotropic effect is seen. The rate increases, the heart rate increases. And because of increase in phosphorylated phospholambin, again calcium uptake is promoted. More and more calcium uptake is promoted, right? Then this causes vasodilatation. Increased calcium release would cause vasoconstriction, and uptake would cause vasodilatation. So it has, the beta agonist has a vasodilatory effect on some organ system, which we will discuss about. And which of the beta receptor? Both the beta receptor, the molecular mechanism is same. They act by the same molecular mechanism. So let us see the beta receptors. We have beta 1, as I told you, only the postsynaptic site, and mostly it innervates myocardium, and in myocardium also atrium much more than ventricles, and then SA nodes, then it also throughout the ventricular conduction system. So, and on kidneys and coronaries. Okay, so when it is activating the myocardium, it produces the inotropic effect, the positive inotropic effect. SA node, positive chronotropic effect, that is heart rate would increase. Alright, kidney, it causes increased renin release, and on coronaries, it causes relaxation of the coronary vasculature. This relaxation would increase the coronary blood flow, So that is why it is increasing the inotropism of the heart, increasing the chronotropism of the heart, helping in relaxation of the heart, right? And increasing the coronary perfusion by the beta 1 agonist effect. The beta 1 agonist would have a very good effect in the ventricular dysfunction, the biventricular dysfunctions, right? Because it has overall good effect on the heart. Beta 2 presynaptic and postsynaptic. Presynaptic on myocardium. Again, opposite to what alpha 2 used to do. Alpha 2 used to inhibit the noradrenaline epinephrine release. It accelerates the norepinephrine release. Then SA node, opposite action to the presynaptic alpha 2, right? It has mostly opposite action to the presynaptic alpha 2 receptor, the beta 2 presynaptic. So it is present on SA node also, right? It is present on ventricular conduction system also. And postsynaptic, like presynaptic, mostly on myocardium, vascular smooth muscle, bronchial smooth muscle, and renal vessels. See, here when it was in smooth muscle, it was augmenting the calcium uptake. So because of the augmentation of the calcium uptake, the beta 2 postsynaptic stimulation would cause relaxation of the vasculature. It will cause relaxation of the vasculature, whether it is the vasculature of the smooth muscle, bronchial muscle, or the renal vessels. So if it is stimulating the relaxation, it is causing the relaxation of the vascular smooth muscle, it will cause vasodilatation. So blood pressure would little decrease. If it is causing relaxation of the bronchial smooth muscle, it will cause relaxation. So it would be good for bronchodilation effect. And on renal vessel, again it will cause relaxation. Got it? So this is the effect of beta 2, right? Now, so these are the two important alpha and beta receptors divided into alpha 1, alpha 2, beta 1, beta 2 at pre and post synaptic sites. Okay. Now we will discuss the individual drugs. We will discuss one by one all the drugs. Okay. So the third important receptor type which I will talk about is dopamine receptor. So we have dopamine 1 and dopamine 2 receptor. Dopamine 1, like alpha 1 and beta 1, is on postsynaptic on blood vessels mostly of renal, mesentery and coronary, and it causes vasodilatation. On renal tubules, it causes diuresis, natriuresis with sodium and water excretion. Then juxtaglomerular cells, it causes renin release, right? Dopamine 2 present on presynaptic and postsynaptic, and presynaptic, it is on postganglionic sympathetic fibers, and it inhibits norepinephrine release. So it modulates the action of norepinephrine. All presynaptic, alpha 1, beta 1, alpha 2 presynaptic, beta 2 presynaptic and dopamine 2 presynaptic modulate the norepinephrine release. Okay, postsynaptic, again like on presynaptic dopamine 1, postsynaptic dopamine 2 receptors on renal and mesenteric vasculature, but the effect is opposite, that is vasoconstriction. Okay, so very complex type of effect. Dopamine 1 causes vasodilatation, dopamine 2 causes constriction of the renal vasculature. Okay, so these are the three important type of receptor: alpha, beta and dopamine receptor, on which the adrenergic drugs would act on. So let us start with drugs now, and let us start with the first drug, that is epinephrine, or popularly called adrenaline. Okay, epinephrine or adrenaline. Okay, now epinephrine or adrenaline, how does it act? What is the receptor on which it acts? So it acts on multiple sympathetic receptor. It acts on alpha 1, beta 1 and beta 2, and I have compared the effect of adrenaline on these three receptor by just making plus sign. So it is most potent on alpha 1, equally potent, more or less equally potent on beta 1, and little less potent stimulant of beta 2. So on alpha 1, alpha 2, beta 1 and beta 2. So if it acts on, let us first talk about effect on beta 1. Mostly epinephrine, we keep in mind when adrenaline comes in our mind, we think more about the positive inotropic effect of adrenaline. We have more potent alpha, we have more important alpha agonist, which are kind of pure alpha agonist for alpha agonism action. Adrenaline mostly we use for its beta action with of course alpha action. It has equally good action on both beta and alpha receptor, but mostly we think about the beta action. So first let us talk about the beta effect of adrenaline on beta 1. So it has a very interesting effect. It is present, adrenaline can stimulate the beta 1, and beta 1 as we know present on SA node, right, and cardiac myocyte, right. Because of stimulation of SA node, it causes increase in heart rate. So this is positive chronotropic effect. Okay, it is positive chronotropic effect. Because of the activation of cardiac myocyte, it has a inotropic effect. So because of this inotropic effect, it will increase the contractility. Okay, contractility. Then it even innervates the cardiac myocyte for better, it causes a better relaxation of the cardiac myocyte also. So causes a better relaxation of cardiac myocyte, and because of this better relaxation of cardiac myocyte, this is called positive luxotrophic effect, relaxation effect, luxotrophic effect. So what is the effect of adrenaline on cardiac vasculature? Positive chronotropic effect, positive inotropic effect and positive luxotrophic effect. All this together would improve the cardiac output. This would improve the cardiac output. All this will improve the cardiac output. Okay. So when this improves the cardiac output, so conditions where we want the cardiac output improve, like in biventricular failure, or when the myocardium is suppressed due to sepsis, we can use adrenaline for its inotropic effect. But remember one thing, that at a very low dose, right, it can have a beta 1 effect with less alpha 1 effect. So if I am using adrenaline for the inotropic effects, the effect on cardiovascular system, we can start it in a low dose. So what low dose? Actually the dose 0.01 to 0.03 microgram per kg per minute will start producing these effects, right? Will start improving the cardiac output. Studies have shown that when adrenaline is given in this, the cardiac index of the patient has been substantially improved. So in a very low dose, the dose of adrenaline is 0.01 to 0.2, right? Not but at very low dose, 0.01 to 0.03 microgram per kg per minute, it can improve the cardiac output, right? So in biventricular failure, adrenaline can be one of the good drugs. When we take out the patient coronary surgery after, let's say, cardiac surgery, after bypass, number of times the myocardium is stunned. Adrenaline works beautifully there also to improve the overall effect of myocardium by increasing its cardiac index by positive inotropic, chronotropic and luxotropic effect. Okay, but I told you the effect is a bit complex. It is doing these good things and it is also doing a bad thing by beta 1 effect. See, when it is causing a beta 1 stimulation, it is increasing the conduction velocity, the conduction of the impulse throughout the cardiovascular system. So it increases conduction velocity and reduces the refractory period, of AV node, of atrioventricular node, of his bundle, even of Purkinje and ventricular myocyte, Purkinje fibers and ventricular myocyte. Plus, it can also activate the latent pacemakers of the heart. So it will start producing a very positive dromotropic effect, that is conduction effect. So positive dromotropic effect. So it will also make the conduction better. Because of this positive dromotropic effect, it has one good use. It can be used in symptomatic bradycardia. So it can be used in symptomatic bradycardia. So when bradycardia is not responding to atropine, we use chronoinotropes, and adrenaline is one of the best chronoinotropes which is available, and the dose is 2 to 10 microgram per minute infusion, right? So this is good thing which it does in bradycardia. But because of this increased conduction velocity, it can also precipitate supraventricular and ventricular arrhythmias. So the side effect of this can be, I would not say would be, it can be, depending upon the stimulation, the degree of stimulation, the condition of the heart, it can cause ventricular and supraventricular arrhythmia. Ventricular and supraventricular arrhythmia. Okay, so this is one side effects because of its beta 1 stimulation of the conduction system. Good effect, we can use it for symptomatic bradycardia, and bad effect, for it can cause arrhythmias. Okay, now let us see when it will affect the alpha 1 receptor, what would it do? I told you that it has effect on beta 1, alpha 1, right? Now let us talk about effect on alpha 1. On alpha 1, as we have already discussed, what is the effect of alpha 1 stimulation will cause? Vasoconstriction of smooth muscle, peripheral smooth muscles, right? Peripheral vasculature, smooth muscle. So vasoconstriction of cutaneous, mesenteric, splenic and renal perfusion, right? Renal vasculature. So it will cause the vasoconstriction of these vasculature. So when the vasoconstriction of these vasculature would happen, the blood pressure would increase, the systemic vascular resistance would increase, and this effect would not be on low dose of adrenaline. It would be on more than 0.1, it would require more than 0.1 microgram per kg per minute of infusion of adrenaline. Then only this effect will start coming. Okay, so this is the let's say vasoconstrictive effect because of the effect on alpha 1 receptor. Now remember that it also increase the vasoconstriction of venous blood vessels. So it can cause venous circulation, venoconstriction, and because of this, if the venous constriction will happen, the preload will increase, isn't it? The increase in preload. So preload of the heart will increase. So blood pressure is increasing and preload is increasing. By its beta action, it is increasing the cardiac output. So overall, it will have a good effect on the cardiac index, on cardiac output. Okay. Okay. Now let us see how does it act on pulmonary artery. On pulmonary artery, it causes with constriction of the pulmonary artery constriction. So it can increase pulmonary artery pressure. So pulmonary artery pressure. So pulmonary artery pressure can also increase. Okay. So by its action on alpha, it can cause pulmonary artery, increase in pulmonary artery pressure. This is again a bad effect of its alpha action. Now remember that what is the effect on coronary perfusion? Now it's very complex. Since it increases the cardiac output by increasing the inotropic effect, by increasing the heart rate, by increasing heart rate, so it is increasing the myocardial oxygen demand. And because of increase in myocardial oxygen demand, the coronary vasculature, to fulfill that demand, the coronary vasculature would go auto-regulation and increase the blood flow. So that it can result in increase in coronary blood flow by auto-regulation, coronary metabolic auto-regulation. But by constricting effect, we have seen that it can cause the alpha, it can cause the on coronary artery constriction by its alpha 1 action, coronary artery constriction. But because if it has a let's say potent effect as a coronary artery constrictor, then it can decrease the coronary artery perfusion. So coronary artery perfusion, right? It can increase can increase by metabolic autoregulation because of increased demand, and this would be more effective in a normal heart. And it can decrease it also, the coronary artery perfusion, by coronary constriction, by constriction of the epicardial coronary vessel, by constriction of epicardial coronary vessel. So it is complex, depends upon, and by beta 1 effect, it can cause coronary artery dilatation also, right? So depending upon what effect predominant and what dose we are using, what is the dose which we are using, the effect on the coronary artery will predominate in that way. Okay, in low dose, maybe the coronary artery perfusion would increase, and in high dose, the coronary artery perfusion will decrease. Okay, so this is the effect on alpha 1. Let us see the effect on beta 2 receptor. Beta 2 receptor mostly innervates the vasculature of the skeletal muscle and it causes vasodilatation. So by beta 2 activation, it will cause vasodilatation, right? That's why it is used, I mean, they are the sympathetic stimulators, and in flight, when the blood flow of the lower limb will increase, then only the person can run away. So that's why by its beta 2 effect, it is increasing the blood flow of the peripheral vasculature of your skeletal muscles. So beta 2 causes vasodilatation of skeletal muscle, vasodilatation of skeletal muscle. And as a result of this vasodilatation, the blood pressure can little bit decrease. The blood pressure can decrease. And it can also cause bronchodilation by beta-2 agonist effect. Bronchodilation. So in bronchial asthma also it has a very big role. You know, adrenaline, I would discuss the uses, and I would say in anaphylaxis it is the drug of choice. Why it is drug of choice in anaphylaxis? Because of its bronchodilatory effect, its vasoconstrictory effect, right? And its effect on stopping of the release of the inflammatory mediators, anti-inflammatory effect, right? So it causes vasodilatation and bronchodilation. So use your effect of adrenaline on your alpha 1, beta 1 and beta 2 receptor, right? So the combined effect would produce the overall effect of adrenaline. In low dose, mostly it is beta stimulant. So in low dose, it will increase the cardiac output by increasing the heart rate, by increasing the contractility, and by improving the relaxation of the heart, and by decreasing the SVR by doing a beta 2 agonist effect. So it will increase the cardiac index and cardiac output. And when the dose is increased, then alpha effect will start coming on, and the alpha effect, it is a potent vasoconstrictor. So it will increase the blood pressure, it will increase the SVR, it will increase the preload by causing venoconstriction. So overall the blood pressure of the patient and perfusion of the patient will increase, and that happens on high dose. And when we are using adrenaline for what reason, we should know the reason, and accordingly we should choose the dose. So what are the different indications of adrenaline? Adrenaline has vast number of indications. It is one of the emergency drug which we always keep loaded in emergency, in operation theaters, in ICUs, everywhere. The most important use of adrenaline in cardiac arrest. It is the emergency drug of cardiac arrest, the drug for both the shockable and non-shockable rhythm. So in VF or PVT or ventricular asystole or in pulseless electrical activity, the drug which we use is adrenaline. And what is the role of adrenaline in cardiac arrest? The role is the vasoconstrictive effect of adrenaline to increase the peripheral perfusion, right? To increase the preload so that when the compression is done, the perfusion is better, right? So to maintain the perfusion, the adrenaline is used in cardiac arrest. So mostly it is not the beta action, it is the alpha action of the adrenaline which is more desirable in your cardiac arrest, right? And adrenaline which we get is a racemic mixture. We don't get a pure alpha or a beta variants. We get a racemic mixture which has both alpha and beta agonists, right? So let us see in cardiac arrest. Cardiac arrest, the dose is 1 milligram, 1 in 10,000 IV, and we need to repeat it every 3 to 5 minutes. Repeat every 3 to 5 minutes. So IV 1 milligram, the whole we give 1 in 10,000. That is why diluting it, the 1 milligram, 1 in 1,000 ample which we get to 10 ml, we give IV the whole and we repeat it every 3 to 5 minutes. For anaphylactic shock, we give it mostly IM, and the dose is 0.1 milligram per kg body weight IM, 1 in 1,000. 1 in 1,000. So for IM, what we get commercially, 1 milligram, 1 in 1,000. Directly we use by the dose 0.1 milligram per kg body weight, right? IM. And we repeat if we don't get the desired effect, and we can go for IV if we don't get the desired effect in anaphylaxis or anaphylactic shock. And IV always 1 in 10,000 dilution is preferred because adrenaline is arrhythmogenic, as I have already told you. It has a positive dromotropic effect. So adrenaline should not be used in less than 1 in 10,000 dilution through IV route. Right, through IM route or subcut route, we can use 1 in 1,000. Okay. For biventricular failure, that is for its beta 1 agonist effect, a low dose is more preferable, right? For biventricular failure, we can start from 0.03 to 0.1 microgram per kg per minute infusion, right? It will increase the cardiac index. For septic shock, right, we give a higher dose. So 0.1 2.2 microgram per kg per minute infusion. For septic shock, why we use it in septic shock? To increase the blood pressure by vasoconstricting effect. So we need more of the alpha action, which comes on a higher dose, right? Symptomatic bradycardia, I told you, because of its positive dromotropic effect, and the dose is 2 to 10 microgram per minute infusion, right? Okay. Apart from these, adrenaline, a potent vasoconstrictor, is used as an adjuvant with local anesthetic for central neuraxial and for peripheral nerve block. We use it in a low dose and very diluted dose, 1 in 2 lakh to 1 in 4 lakh dilution, right? For subcutaneous infiltration, the surgeons used for dental surgeries, for plastic surgery, to decrease, for causing a vasoconstriction and for decrease the blood loss. Use it for fist surgery, the ENT surgeon use, right? They use it for subcutaneous infiltration to decrease the bleeding. And what is the dilution they use? 1 in 1 lakh to 1 in 1,50,000. Okay. Then we use it through inhalational route to decrease the mucosal edema. So for decreasing the mucosal edema, we use it by inhalational route, right? To decrease the mucosal edema. We use it in croup, in pediatric, right? Through inhalational route, we can use inhalational route, right? We can give it through nebulizer. We can give it both through nebulizer. It decreases the edema very quickly. Number of times post extubation, if we have a bleeding anedema and patient blood pressure is fine, we can go for a adrenaline nebulization also, right? In that, we take 1 in, let's say 10,000, 2 ml of it, we dilute it with 5 ml of normal saline and we use it for nebulization. Okay. Epidural test dose. For epidural test dose, 5 microgram per ml concentration is used. Right? That is 4.5 to 5 microgram. 4.5 to 5 microgram concentration is used for epidural test dose. Whether to see the epidural catheter is not touching a vessel, right? If I will give adrenaline and if it is touching the vessel, immediately we will get a increased blood pressure will shoot up and we will know it. So for these different uses, we are using adrenaline, a very important sympathomimetic drug, right? Used in treatment of the patient with diseased myocardium, in patient with hypotension, right? Depending upon the dose, it has a variable uses, right? And so one of the most important drugs. Now coming on the next drug, or before the next drug, let me show you how do we prepare adrenaline. This is a ampoule of adrenaline which we get. This is 1 milligram adrenaline 1 in 1000, right? 1 milligram adrenaline 1 in 1000. So in one ampoule, we have 1 ml 1 in 1000, that is 1 milligram per ml. What we do, we take, if I have to make a infusion, we take 3 milligram, we take 3 ampoule of this adrenaline, 3 milligram in 47 ml of normal saline and make it 50 in a 50 ml syringe. So 50 ml is now, it is 50 ml, the total volume is 50 ml, 3 milligram of adrenaline in 47 ml of normal saline, that is 3 ml, 3 milligram adrenaline in 47 ml of normal saline. So now in 50 ml, we have 3 milligram, that is 3000 microgram. So we have 3000 microgram. So 1 ml would contain 60 microgram per ml, 60 microgram per ml. So this is for infusion we make 60 microgram per ml. So whatever is we are giving, whatever the rate of infusion we are giving, if we are giving 1 ml per hour infusion, right? The dose which is going is 1 microgram per kg, right? 1 microgram per kg per minute, the infusion rate is going. So if I am giving my, let's say 60 kg patient, right? I am giving the infusion 2 ml per hour. So what is the dose going? 2 ml per hour, 2 divided by the body weight by microgram per kg per minute. What I am saying, 1 ml per hour, but the ml divided by body weight, sorry, I wrote it wrong. the ml divided by body weight, that much microgram per kg per minute. So 2 divided by body weight. So 2 divided by 60 microgram per kg per minute infusion is going, right? So 2 by 60, let's say it comes out to be 0.03. So 0.303 microgram per kg per minute we are giving the patient. Okay. So what you have to do? You have to take 3 milligram of adrenaline, mix it with 47 ml of normal saline. Now 60 microgram per ml, the strength has been prepared. And now when you will give the infusion, at whatever rate you are giving the infusion, 2 ml, 3 ml, you have to divide that infusion rate with the body weight. That much microgram, right? Microgram the patient is getting per kg per minute infusion. So if I am giving the 3 ml per hour infusion, what my patient is getting, of my 60 kg patient is getting 3 by 60 microgram per kg per minute infusion, right? That comes out to be 0.05 microgram per kg per minute. Okay. So simply you have to divide the infusion rate with the body weight. That much microgram per kg per minute is going to the patient. So easy way to calculate and titrate the dose, right? And we know that according to the requirement, we have to titrate the dose. For let's say cardiac arrest management, this is 1 milligram adrenaline, 1 in 1000. We dilute it to 10 ml. We have to give whole 10 ml, right? But we have to give it in a dilution of 1 in 10,000. So for cardiac arrest management, we have to give 1 in 10,000. 1 milligram, 1 in 10,000. Okay. So this is how we prepare our adrenaline for infusion and for the bolus. Okay. Now the next drug which I will discuss with you is norepinephrine, another important drug, norepinephrine. Now norepinephrine, it is kind of more potent, it has more potent effect on alpha receptor, right? It is more used for the vasoconstriction effect. So norepinephrine, or popularly noradrenaline. Okay, alpha 1 effect plus 5 plus I have written. For alpha 2 I have written 2 plus, and for beta 1 I have written 3 plus. Okay, it has a good beta effect also, undoubtedly, but alpha effect predominant, and alpha effect is the reason for which it is more commonly used clinically. So let us see the alpha effect. Alpha effect of noradrenaline: intense vasoconstriction, right? Because of this intense vasoconstriction, arterial and venous blood vessel tone increases. So arterial, so increased systemic vascular resistance, increase diastolic pressure, or by venous constriction, increase venous return, so increase in preload. So both preload and afterload is increased. So both preload and afterload is increased. So minimal effect on cardiac output. So initially minimal effect on cardiac output, We are mostly using it for in management of hypotension, and in hypotension already patient has tachycardia. So when we give noradrenaline, the blood pressure goes towards an acceptable or normal side. So this would inactivate, this elevated arterial pressure would activate baroreceptor mediated the reflexes, and the heart rate will increase. So less tachycardia by baroreceptor mediated reflex activation, right? If blood pressure is low, the baroreceptor mediated reflex action increases the heart rate. If blood pressure becomes high, the baroreceptor mediated reflexes decrease the heart rate. So therefore less tachycardia. On pulmonary and on pulmonary vasculature, it causes pulmonary vasoconstriction, right? Because of the pulmonary vasoconstriction, it increases pulmonary vascular resistance, right? Pulmonary vascular resistance. And because of increased vasoconstriction, right, it would decrease the blood flow to hepatic, mesenteric, and the other hepatic, mesenteric, and renal system. So it decreases blood flow because of vasoconstriction, blood flow to hepatic, mesenteric, and renal blood vessels. So when we are giving noradrenaline infusion for a long duration, we have always a risk of decreased blood flow to these organs, and dysfunction or hypoxia can happen to these organs, right? But if blood pressure is also not maintained, then also the perfusion will be affected. So we have to balance in a very careful way, not to affect the perfusion of these organs much also, and not to let the blood pressure also fall below certain limits. So we have to titrate the dose properly of noradrenaline. Okay, so basically the use and the dose I will tell in a few seconds. So now on beta 1 receptor. Beta 1 receptor, we have already discussed. Beta, mostly the inotropic on cardiac myocyte, on SA node. So inotropic, chronotropic, dromotropic effect. So beta 1 receptor increases contractility of heart, augments stroke volume. It will help, augments stroke volume, right? And by alpha 2 effect, it increases the coronary perfusion, right? It increases coronary perfusion. Beta 2 decreases coronary perfusion. Alpha 2 increases coronary perfusion. So coronary perfusion, because it causes relaxation of the coronary artery, perfusion improves, right? Improves. Coronary perfusion improves. So this is the effect on these three receptors. Mostly it is used for its alpha 1 effect to produce intense vasoconstriction in refractory shock, which is not responding to the fluids and blood volume replacements. So what is the use? The most important use of noradrenaline is in septic shock. In septic shock, this is the first line of drug to manage, first line of inotrope to manage hypotension. The dose is 0.01 to 0.2 microgram per kg per minute infusion. This is an important dose. For vasoplegic syndrome, in vasoplegia, along with the nitrovasodilator, noradrenaline is used to maintain the perfusion, right, and to increase the blood flow to the organs also. So used along with nitrovasodilators. Okay, hypovolemic shock, till we are replacing the volume, with blood products, we have to maintain the perfusion. So again, this is the first line of management. Dose is same, 0.01 to 0.2 microgram per kg per minute. So this is the range of the dose. Remember, always start with a low dose, then gradually increase, because you have to carefully balance, because it will increase the blood pressure, no doubt, but it will also decrease the blood flow to the other organs, which can cause hypoxic injuries to the other organs. So we have to very carefully balance, right? We have to very carefully balance the dose. Now, if you have seen a noradrenaline ampoule, now this is a NORAD ampoule. It is 2 ml. Its content is 2 ml. 2 ml, that is 2 milligram of noradrenaline present in. 2 ml has 2 milligram of noradrenaline. 1 ml, 1 milligram of active noradrenaline. So if I take this ampoule, one ampoule has 2 ml, 2 milligram of noradrenaline. Okay, like adrenaline, same way we prepare, we can very easily titrate the dose. So what I will do, I will take 3 ml. 3 ml means, that is, I will take one full ampoule and 1 ml of another ampoule. I will take 3 ml, add 47 ml of D5 or normal saline. We can prepare in D5 or normal saline. 1 ml will now contain 60 microgram. As in the last adrenaline, I calculated, right, that 3000 microgram comes out in 3 ml. 3 milligram. 3 ml has 3 milligram, and 3 milligram is 3000 microgram. Now this is in 50 ml. So 1 ml is your 60 microgram. So 1 ml is 60 microgram of noradrenaline. And when you start the infusion, the rate with which you are infusing, that rate divided by body weight, microgram per kg per minute, is what you are giving to your patient. So again, if you are giving to your patient 3 ml per hour, that is 3 divided by 60, and that is 3 divided by 60 microgram per kg per minute. That comes out to be 0.05 microgram per kg per minute infusion is what we are giving, right? So dose is 0.01 to 0.2 microgram per kg per minute, and we have to very carefully balance the dose. So this is how we prepare NORAD. Noradrenaline and adrenaline should be prepared in same way, right? Same way the infusion is prepared. Okay. So this is about our noradrenaline. The next important drug which I will discuss with you is your dopamine. Dopamine, the dopamine receptor which I talked about, the specific receptor on which the dopamine acts. So we have, and the, I told you in the beginning itself that it depends upon the receptor on which the drug acts. It depends upon the dose in which the drug is given. It depends upon how the receptor is, the frequency of the number of receptor occupying a particular organ site. It depends upon all the action what we will get when we are using these drugs. Now, dopamine acts in low dose mostly on dopamine A and dopamine 1 and dopamine 2 receptor. So, dopamine exerts major effect by activation of dopamine 1 and dopamine 2 receptor. So 5 plus I have given. It can also act on alpha 1 receptor, and it can also act on beta 1 receptor, right? Alpha 1 and beta 1 receptor. Alpha 1, it can 3 plus I have given, and beta 1 I have given 4 plus. So it will have the vasoconstrictive effect also, it will have inotropic effect also, and it will have some effect through dopamine receptor also, which we talked in beginning, that dopamine receptor are mostly present on renal vasculature, mesenteric vasculature, right? So let us see what is the effect when it acts on dopamine and dopamine 2 receptor. The dose in which it acts on these dopamine receptor predominantly is less than 3 microgram per kg per minute infusion, less than 3 microgram per kg per minute infusion. So when I give it in less than 3 microgram per kg per minute infusion, it acts on dopamine 1, dopamine 2 receptor. So when it acts on dopamine 1, it dilate the renal, mesenteric and splenic arterial blood vessel, and by acting on dopamine 2 receptor, it decreases noradrenaline release, modulatory effect on noradrenaline release, decreases noradrenaline release from pre and post ganglionic sympathetic neurons, from pre and post ganglionic sympathetic neurons. Okay. So less than 3, it is acting mostly by dilating the renal blood vessels. So if the blood vessel will dilate, the blood flow will increase. So is it renal protective? Does it act as renal protective? Well, previously it was thought that it has a very good renal protective effect. So number of times in when the urine output of the patient used to decrease for its renoprotective effect, in a less dose dopamine was used. But today this role is questioned. The research and the studies have shown that it does not offer much of the renal protection in this dose, even by little bit increasing the renal blood flow. Rather than targeting on increasing the renal blood flow in hypovolemic shock or in septic shock, we have to target more on increasing the systemic blood pressure. Systemic blood pressure once increased, the perfusion of all the organ would get better, right? So its renoprotective role is now questioned. So not much used nowadays for its neuroprotective effect. Now coming on effect on alpha 1, on 3 to 8 microgram, less than 3, it used to act only on, it acts only on dopamine receptor. Between 3 to 8 microgram per kg per minute, it acts on alpha 1 and beta 1 receptor, right? Both alpha 1 and beta 1 adrenoreceptor. So what would be the effect of alpha 1 and beta 1? Alpha 1, so it will increase the blood pressure. Beta 1, it will cause positive inotropic effect, So both it is increasing the blood pressure and cardiac contractility and heart rate. More than 10 microgram per kg, mostly alpha 1 effect. So vasoconstriction. So if very high dose we are using, it is mostly to increase the blood pressure, mostly for vasoconstriction, right? So what is the use of dopamine in today's scenario, today's practice of using these drugs? What is the current use of dopamine? The current use of dopamine is in shock in the dose 2 to 20 microgram per kg per minute. In this dose, 2 to 20 microgram per kg per minute, it is used as second line of vasopressor after NORAD, second line of vasopressor after NORAD, to increase the blood pressure of the patient. So if noradrenaline we are given the dose which we want to give, and we want to add another inotrope with it, definitely dopamine is the second line of therapy. So with after noradrenaline we add dopamine, right? Okay, we use it for symptomatic bradycardia. In symptomatic bradycardia, for it is also a chronoinotrope, right? It is increasing the blood pressure, right? It is increasing positive inotropic effect. It is increasing the heart rate also. So it is chronoinotrope, symptomatic bradycardia. Symptomatic bradycardia, the dose is 5 to 20 microgram per kg per minute. Basically, the dose ranges from 2 to 20 microgram per kg per minute. Both it's the vasopressor dose and its dose for managing bradycardia, right? So remember the dose 2 to 20 microgram per kg per minute. Okay. Okay, so this is the two important role of dopamine in today's clinical practice. Its renal protective effect is now no longer recommended. Though the old school of thought, they still say that in less dose it shows some renoprotective effect, but not much in data, and the research does not support it. Okay, now let's see how we prepare dopamine. Now dopamine, this is an ampoule of dopamine. One ampoule of dopamine has 200 milligram in 5 ml, that is 40 milligram per ml, per 1 ml is the strength of this ampoule. So 200 milligram in 5 ml. So what is how do we prepare this for infusion? How do we prepare dopamine for infusion? We always use it in infusion. So how do we prepare it? So to prepare it, we have to, how much we have to mix in the syringe. So amount of drug required for preparing the infusion in a 50 ml syringe I am talking about. We take 3 times the body weight, 3 times the body weight. So if body weight of the person is 40 kg, I take 3 times the body weight, that is 120 milligram of dopamine. 120 milligram of dopamine. So I told you 40 milligram in 1 ml, so I will take 3 ml. So when I take 3 ml of dopamine, I dilute it with 47 ml of normal saline or D5, right? Now I have a 50 ml volume. So now when you will give the infusion, whatever infusion you are giving, in ml per hour, the infusion we are giving in ml per hour, the dose what is going to the patient is your in microgram per kg per minute. What do I mean? If I am giving 5 ml per hour, so what patient is receiving? 5 microgram per kg per minute infusion, right? 5 microgram per kg per minute infusion. Got my point? So 3 times the body weight we are calculating, we are mixing it in 50 ml, and then whatever infusion we are giving that rate in microgram per kg per minute, the dose to the patient. So dose is 2 to 20 microgram per kg per minute. If I am giving 5 ml per hour, I am giving 5 microgram per kg per minute. If I am giving 8 ml per hour, I am giving 8 microgram per kg per minute infusion. In adrenaline and NORAD, whatever the rate we had set, we had to divide it by the body weight, that much microgram per kg per minute we were giving. Here, whatever rate we have set, that much microgram, we don't have to divide by body weight, that much microgram per kg per minute we are giving in the infusion. Got it? So this is how we prepare dopamine. Now next important drug is dobutamine. Now let us talk about dobutamine, which is a synthetic catecholamine, right, which contains 2 isomers. It is a synthetic catecholamine. Adrenaline, noradrenaline, dopamine, they were natural catecholamines. They are prepared also, but they are natural catecholamine also. Dopamine is precursor of adrenaline, right? So synthetic catecholamine contains two isomers, contains two stereoisomers, right? Minus and plus, and both of which stimulate beta receptor. Both this minus and plus will stimulate beta adrenoreceptor, right? But how does it affect beta? Both will have a stimulant effect. So on beta adrenoreceptor, both will have stimulant effect. So in beta 1 I have written 5 plus, and beta 2 I have written 3 plus. But what about alpha? What is the alpha effect? Alpha 1 effect. Well, this minus and plus has antagonist effect on alpha receptor. Minus has agonist and plus has antagonist, agonist antagonist effect. So overall effect on the alpha receptor is nil at a low dose, at a normal dose, which we will talk about. But at a high dose, little agonist effect is seen, which I will talk about. Okay, so these basically, it is stereoisomer which has plus and minus two stereoisomer present. It is a racemic mixture which has two stereoisomer present. Both the stereoisomer has a positive effect on the beta receptor and agonist antagonist effect on the alpha receptor. So it is kind of predominant beta effect is what we get from dobutamine at the dose which we use normally in the patient. So mostly it will be used as a inotropic agents. How it will be used as inotropic agent? So by its effect on beta 1 and beta 2 receptor, right? Okay, in less than 5 microgram per kg per minute infusion. Right, dose is again 2 to 20 microgram. If I am giving less than 5 microgram, it will have positive effect on beta 1, beta 2, and even on more than this dose, it will have positive effect. So less than 5 microgram, above 5 microgram per kg per minute. On beta receptor, it will always have a stimulant effect. So on beta 1, it increases contractility, and beta 2, it decreases the skeletal muscle tone. So arterial tone decreases, right? Arterial tone decreases. So little bit decreases the blood pressure. So this would increase contractility and decrease afterload by decreasing the blood pressure, makes the left ventricular arterial coupling better. So makes left ventricle and arterial coupling improved. So myocardial efficiency improves, cardiac output improves, both in absence and presence of cardiac dysfunction. Both in absence and presence of myocardial dysfunction. So guys, remember, if you are using it in less than 5 microgram per kg per minute dose, okay, it will produce increase in contractility, but it can decrease the blood pressure by this beta 2 effect, because in any dose it is beta stimulant, right, only. And for alpha effect, we need to increase the dose. When we increase the dose, then it can increase the blood pressure also, right? It can increase the systemic blood pressure also, because alpha effect will increase. But till 5 microgram per kg per minute, it will mostly have inotropic effect. So if the dose is more than 5 microgram, per kg per minute, right? Less than 5 microgram per kg per minute, less than 5 microgram per kg per minute, agonist and antagonist effect on your alpha receptor, alpha adrenoreceptor. Okay, more than 5 microgram, this negative isomer, this would progressively stimulate the alpha. It will stimulate alpha 1 adrenoreceptor more, right? So this would decrease, this decreases beta 2 vasodilatation. This was causing decrease in blood pressure by decreasing by beta 2 vasodilatation. This would decrease the beta 2 vasodilatation effect, right? So this would preserve the preload, afterload and arterial pressure. So together it can preserve LV preload, afterload and even the blood pressure, right? But remember, dobutamine causes imbalance between the myocardial oxygen supply and demand. So myocardial ischemia can get precipitated with dobutamine. This is one major issue of dobutamine. So use of dobutamine and plus dobutamine effect on heart, the cardiostimulant effect, the inotropic and the chronotropic effect on heart is not like it is more dose dependent, right? So number of times we don't get the expected result we want with dobutamine. So in case of if you want to use to increase the cardiac contractility after CABG surgery, after taking the patient out of the bypass and all, it's better to use adrenaline. Adrenaline has more known effect on cardiac contractility. It will have more defined effect on cardiac contractility. And dobutamine research have shown that effect can be little dicey, right, as compared to adrenaline. So adrenaline is always a better drug when we are using for inotropic effect. Okay, on heart rate, it can do anything. It can increase heart rate by beta 1 adrenergic effect. It can decrease heart rate, right? It can decrease heart rate. It can decrease heart rate by increasing the blood pressure and decreasing the sympathetic tone. Then it can improve the cardiac output. It can increase the cardiac output, right? So if it increases the cardiac output, tissue perfusion will increase. So LV preload, afterload, preserve. It increases the BP, increases the cardiac output. So tissue perfusion improves to some extent. Tissue perfusion improves. But again, I would say the effect is dependent upon the dose. The effect is dependent upon the dose, right? And its effect on beta 2. It also affects beta 2 adrenoreceptor. It stimulates which is present in pulmonary artery. It decreases the pulmonary artery pressure. By its beta 2 effect, it decreases pulmonary artery pressure. It decreases pulmonary artery pressure by beta 2 adrenoreceptor stimulation, right? Okay, this where do dobutamine is more used? Dobutamine is more used in depressed myocardium by, let's say, sepsis or post CABG surgery. So indication, it is inotropic support to depressed myocardium. Okay, it is used as an inotropic support to depressed myocardium in 2 to 20 microgram per kg per minute infusion. 2 to 20 microgram per kg per minute infusion. And we use it even for dobutamine stress echocardiography test. Pharmacological stress we do exercise echocardiography, stress echocardiography. But if some number of patient who cannot be mobilized in that way, we go for dobutamine stress echocardiography test. We give dobutamine infusion to the patient and we see the patient myocardium can respond to that increased demand or not by increasing its cardiac output and by increasing the heart rate. So we use it for dobutamine stress echocardiography also. So these are the two important roles. See, dobutamine, remember, if you are giving in less dose, it will decrease the blood pressure. It will not increase the blood pressure. So if it will not increase the blood pressure, if patient already is in hypotension, it would not be a good inotropic to be used, right? If you increase the dose, right? If you increase the dose, It has shown a lot of arrhythmogenic effect also, and increasing the dose definitely would counteract the hypotensive effect of dobutamine. But there are much better other drugs to be used in those scenarios, right? Like, so dobutamine mostly sepsis patient with depressed myocardium. For post CABG patient also coming out of bypass, the cardiac patient after cardiac surgery also, adrenaline would act better than dobutamine. Adrenaline is a better drug to be used for positive inotropic effect. Okay. Okay. So how do we prepare it? So this is the dobutamine ampoule. Okay, this is a dobutamine ampoule. Now, one ampoule contains 250 milligram in 5 ml, and this means that 50 milligram per ml. Amount of drug, same, it is calculated in the same way as dopamine. For 50 ml solution, body weight into 3, 70 kg we need, let's say 210 milligram, 17 to 3, 210 milligram. So 4.2 ml of drug is required. 1 ml contains 50. So 50 into 4, 200, and 0.2 for another 10 ml. So 10 milligrams. So 4.2 ml is required. Rate of infusion will correspond to rate in microgram per kg per minute. So if you give 3 times the body weight in the 50 cc syringe, whatever infusion rate you are giving, if you are giving 4 ml per hour, the what patient is getting is 4 microgram per kg per minute. 4 microgram per kg per minute infusion, right? Dose is 2 to 20 microgram per kg per minute infusion. Okay, so this was dobutamine. The next important drug we will discuss is isoproterenol. Not much in clinical use nowadays. Isoproterenol. This is what? A non-selective beta adrenergic receptor, right? So now we are coming on more dividing alpha and beta action separately to be used where we specifically want to use these drugs for. Till now, the drugs which we use had both alpha and beta effects. Now let us see the drugs which has effect on one of the receptor predominantly. No drug can be devoid of any effect on, devoid of total effect from any receptor, but there are some selective drugs which we will talk about. So isoproterenol, this is non-selective beta adrenoreceptor agonist. Okay. So it will act on beta 1 and beta 2, non-selective on beta 1 and beta 2, does not act on alpha receptor. So beta, so it is 5 plus on beta 1, 5 plus on beta 2, very good beta agonist effect. So since it is a beta agonist drug without alpha effect, the predominant role of this drug was used, it was used as a pharmacological pacing agent, right? When the heart rate was less, it was used to pace the heart by increasing the chronotropic effect. So it was used for pharmacological pacing, right? It is used in symptomatic bradycardia, bradyarrhythmia and AV conduction block. Bradycardia, bradyarrhythmia or AV conduction block, right? This is very effective to increase the heart rate in cardiac transplant patient, in denervated heart. So it is also very effective used in cardiac transplantation to increase heart rate in denervated heart. Okay. Now remember, today pacing has kind of replaced this. So transcutaneous and transvenous pacing has kind of replaced this pharmacological pacing effect of isoproterenol. So use has somewhat decreased. Now it causes, the reason why the use has decreased because of the effect on the right ventricle it has. It causes right ventricular dysfunction. Severe pulmonary artery hypertension. Severe pulmonary artery hypertension. by effect on beta 2 adrenoreceptor, by having effect on beta 2 adrenoreceptor in pulmonary vasculature. By beta 2 adrenoreceptor, it causes severe pulmonary hypertension. Beta 2 adrenoreceptor causes pulmonary vasoconstriction, and there is no alpha to counteract and cause pulmonary vasodilatation. So because of that beta 2 predom effect, it causes pulmonary arterial hypertension. Pulmonary arterial hypertension. The major side effect, increase in heart rate. So this increase in heart rate will increase the myocardial oxygen demand, and coronary ischemia can get precipitated. So this drug nowadays not very commonly used. We can do this pacing effect by transcutaneous and transvenous pacing without having these deleterious side effect on the heart. Now, how do we prepare it? If you see the image of the isoprenaline, right? Isoprenaline image, 1 ml. We have two kind of ampoule available. 1 ml with 0.2 milligram, but what I have given in the image is 1 ml 2 milligram. Okay, 1 ml 2 milligram. So 2 milligram in 1 ml, we dilute it to 10 ml. So now 1 ml has 0.2 milligram, 0.2 milligram. We again dilute it to 10 ml. Now it has 0.02 milligram in 1 ml. Now this dilution is what we have to use, because the dose is what? The dose is 0.01 to 0.02 milligram, right? Bolus. If I'm using it for bolus, 0.01 to 0.02 milligram boluses we use. And if I'm using it for infusion, then 2 to 10 microgram per kg per minute is what we can use, right? 2 to 10 microgram per kg per minute. So 0.02 dilution is what we prepare if we are using for boluses, right? In 0.01, 0.02 milligram bolus doses we are using it. Okay, isoproterenol. It's called pharmacological pacing agent. Pharmacological pacing agent. Okay, so this is a pure beta agonist, which is used for increasing the heart rate, It is more for chronotropic effect we are using it. Okay, but it has a lot of side effects, It causes RV dysfunction and all. It causes coronary ischemia. So not so commonly used nowadays. Now next important drug. So we discussed about pure beta 2 agonist. So let us talk about beta agonist. Let us talk about more alpha agonist. Okay, so phenylephrine. Phenylephrine is, as it is the name, phenylephrine. Structurally, it is related to epinephrine with only one difference, and that difference prevents its having an effect on beta receptor. The difference is hydroxyl group on the phenyl ring of the epinephrine. So phenylephrine is structurally related to epinephrine. Minor difference, and the minor difference makes a major difference in the pharmacological effect. Minor difference in the structure, no hydroxyl group on phenyl ring. So this makes it phenylephrine. Okay, it exerts major effect by activation of alpha receptor. So alpha adrenergic receptor, it is alpha adrenergic receptor. Mostly it is having effect on alpha. So by alpha 1 stimulation, what will it produce? It will increase the blood pressure, increase the heart rate by increasing the arterial tone. By increasing the venous tone, it will increase the preload by increasing the venous tone. So it will increase blood pressure. So reflex sympathetic activity would decrease the heart rate. So it will decrease the heart rate by reflex sympathetic activity. Cardiac output preserved. Cardiac output is preserved. So it preserves the cardiac output, right? See, if on LV function it has no such effect, but if the left ventricle is failing, then this increase in blood pressure, the increase afterload cannot be tolerated by the failing left ventricle, then cardiac output will get affected. So cardiac output is preserved, but in failing heart, in failing left ventricle, when left ventricle is not working properly, failing left ventricle, increase in afterload can decrease the cardiac output, It can also increase pulmonary artery pressure by vasoconstriction, pulmonary artery pressure increases. One important thing about this, it is not arrhythmogenic. The best part is it is not arrhythmogenic. Not arrhythmia, it doesn't have a dromotrophic effect, not arrhythmogenic. So whenever we have hypotension with tachycardia, this is very good drug. It causes hypertension and it decreases the heart rate. It causes bradycardia. So how do we prepare it? This is one phenylepinephrine preparation and two exactly. One is 10 milligram per ml what we get, and other is 500 microgram, or rather I should write that 100 microgram per ml, right? We have two kind of preparation, 100 milligram per ml, 100 microgram per ml. Even diluter form also we get. So let us talk about first how we prepare the 10 milligram per ml preparation. The dose of phenylepinephrine, what is the dose? The dose is 0.15 to 0.75 microgram per kg per minute infusion, and bolus dose which we use in hypotension, the bolus dose is 0.1 to 0.5 microgram, 0.1 to 0.5 milligram, that is 100 to 500 microgram. This is the bolus dose, 100 to 500 microgram. So 10 milligram in 1 ml, such a high concentrated form. So we take this 1 ml, dilute it with 10 ml normal saline. So now I get in 1 ml 1 milligram. Again I dilute it with 10 ml of normal saline. So now what do I get? Now I get 1 milligram, 1 ml in 1 milligram, I dilute it to 10 ml. So now I will get in 1 ml we have 1000 microgram, I dilute it to 10 ml. So I get 100 microgram per ml. So now I am getting 100 microgram per ml. So by double dilution, I am producing 100 microgram per ml. So this is what we use for bolus. Bolus dose is 100 to 500 microgram per ml. So 10 milligram in 1 ml, we dilute it to 10 ml, we get 1 milligram. Again we dilute it to 10 ml, we get 100 microgram per ml. Because 1 ml, that is 1 milligram is 1000 microgram. I dilute it to 10 ml, now I get in 1 ml 100 micrograms, right? We get 100 microgram. That is what we use for bolus dose. Okay, this is how we prepare phenylepinephrine. We get a diluted version also. So diluted version is 100 microgram per ml. Very commonly nowadays it is being used for treating post-spinal hypertension, especially in OPS patient, because it doesn't cause fetal acidosis, right? Phenylepinephrine nowadays is considered the vasopressor of choice for post-spinal hypertension, especially in OPS patient and in cardiac patient. This is the vasopressor which is not causing tachycardia. Remember, it is not causing tachycardia. So reflex bradycardia can be caused by it. So keep this side effect in mind. Okay. Next drug is ephedrine. Just few points about ephedrine. Right, ephedrine, it has very unique kind of effect, direct and indirect effect. So ephedrine, this has two effect, direct effect, indirect effect. What about the direct effect of ephedrine? Direct effect like epinephrine. It produces increase in heart rate, increase in cardiac output, increase in SVR. This two by beta effect and this by alpha effect. Okay, this direct effect is less potent. This is less potent. Okay. Indirect effect is more potent. And what is the indirect effect? Indirect effect is that it causes, when we give IV ephedrine, endocytosis of ephedrine is happened into alpha and beta 1 adrenoreceptor presynaptic postganglionic nerve terminals, and this causes increased release of norepinephrine. By indirect effect, endocytosis of ephedrine into alpha 1 and beta 1 adrenoreceptor presynaptic postganglionic nerve terminal. Postganglionic nerve terminals. Endocytosis happens, and when this endocytosis of ephedrine happens, it displaces norepinephrine. So this displaces norepinephrine. Epinephrine. Right? So the predominant effect is through this norepinephrine. So whatever would be the NORAD effect, that is the predominant effect of norepinephrine is to increase the blood pressure. So this is the predominating effect. Right? Now remember, this is the predominant effect, indirect effect, and this is because of the release of norepinephrine from the postganglionic nerve terminal. Once this gets depleted, the effect gets depleted. So tachyphylaxis, this drug, tachyphylaxis has been seen. Tachyphylaxis, right, of ephedrine has been seen. So let us see the dose of epinephrine. First, let us see how do we get it. We get 50 milligram per ml, right, 50 milligram per ml ample. Okay, the dose, the bolus dose we use for hypotension treatment because of its predom norepinephrine effect is 5 to 10 milligram, right, IV bolus. So we take 50 milligram, dilute it with to 10 ml. So now we have 5 milligram per ml. Okay, so we use it for bolus injections. Okay, so and maximum dose which we can give in one time is 50 milligram. So 5 to 10 milligram IV bolus, not to exceed 50 milligram, right? Why? Tachyphylaxis happens, so it will not have more effect than this. Okay, now let us talk about mefentramin. Again, one of the common drug which you use for treating post-spinal hypotension as a vasopressor. Mefentramin is alpha 1 agonist, again like your phenylephrine, alpha 1 agonist, right? So it would increase the blood pressure, it will increase the cardiac output. Heart rate changes according to the vagal tone. So basically it is used to increase the blood pressure, right? So if you see mefentramin which is available, mefentramin we get 10 ml vial in which 1 ml has 30 milligram of mefentramin, 30 milligram of mefentramin. So what we take this 1 ml, dilute it, let's say with 5 ml, 1 ml 30 milligram mefentramin with 5 ml normal saline. So now we get 6 milligram per ml. We get 6 milligram per ml. We use it for bolus injections. The dose is 6 milligram to 12 milligram boluses. This is the dose, right? So mefentramin is also used for treating the post-spinal hypotension. Okay, so if I have a patient with hypotension in intra-op period, what would be the drug we would use for what vasopressor we would prefer? First, we will see why the hypotension is happening. Is the depth of anesthesia too deep? That is, our anesthetic agents, all are vasodilators. So is it too high? How would I check it? I can check it by BIS. I can check it by MAC. So yes, if the depth is too much, I would decrease the dose of anesthetic agent, inhalational or IV. If depth is not high, right, then we will see whether the patient is responding to fluid or not. If patient is fluid responsive, we will give fluids. We give little fluids and try to increase the BP. If patient is not fluid responsive, right, then we will see the heart rate. If heart rate is high, we will give phenylepinephrine. If heart rate is low, we would preferably use ephedrine. Now, mifentromine can also be used, right? Change in the heart rate produced by mifentromine is depending upon the vagal tone, so less predictable. So that's why if we have a real increased heart rate, very high heart rate, we go for phenylepinephrine, and low heart rate we go for ephedrine, because we don't know the predictable effect which they will produce. Mifentromine does not have a predictable effect on your heart rate. Plus mifentromine causes too much of fetal acidosis. So nowadays in post-spinal hypotension management, its role for managing maternal post-spinal hypotension is little bit decreased. Okay, so these were the inotropes which I wanted to discuss. Now very quickly just summarize. So I talked about epinephrine, norepinephrine. I talked about dopamine, dobutamine, these four main, isoproterenol and phenylepinephrine. So your epinephrine, alpha action, beta 1 and beta 2 action. Dopamine action, 0. What are the main clinical indications? Shock, anaphylaxis, cardiac arrest and symptomatic bradycardia. What are the major side effects? Arrhythmia, supra or ventricular arrhythmias. Myocardial ischemia, by increasing the myocardial oxygen demand, right? So very thin line, how do you use it? It can preserve the myocardial blood flow, it can cause myocardial ischemia also. Sudden cardiac arrest has been seen with it. If you give IV, a very high concentration, 1 in 1000, sudden cardiac arrest has been seen with this drug. Why? Because it is arrhythmogenic, highly arrhythmogenic. Then hypertension, by sudden shoot of the BP, and stroke can be seen. So you have to give it in a very mannered way, in a very titrated way. Norepinephrine, more alpha action compared to beta action, though it has a good beta action also. No dopamine action. Mostly used in shock. What are the side effects? Arrhythmia, bradycardia, because it will increase the blood pressure. So reflex sympathetic activity, heart rate can decrease. Peripheral ischemia, by decreasing the blood flow to the peripheries. Tissue necrosis on extravasation and hypertension, of course. So these are the side effects which we have to keep in mind, right? Norepinephrine is major vasopressor which we are using as the first line of treatment in septic shock and in your hemorrhagic shock also, right? Then dopamine. Dopamine has effect on dopamine receptor in less than 3 microgram per kg per minute infusion, both on alpha and beta receptor from 3 to 10, and more than 10 it has effect on more than 10 it has effect only on alpha receptor. So depending upon what use you want to have for dopamine, accordingly you will titrate dose. Mostly used as second line of therapy in shock for cardiogenic and vasodilatory shock, and for symptomatic bradyarrhythmias. We are using for symptomatic bradyarrhythmia. Major side effect, arrhythmia, MI, peripheral ischemia, hypertension. Whatever, all catecholamine more or less have same side effects. Dobutamine, beta action, predominantly beta action. Mostly it's an inotropic agent. Alpha action minimal due to the negative racemic, due to the stereoisomer, the negative stereoisomer. On high dose, little alpha action can be seen, but its alpha action is agonist antagonist by its racemic mixture by negative and the positive stereoisomers. Mostly beta effect, used in low cardiac output, congestive heart failure, cardiogenic shock, sepsis induced myocardial dysfunction, and in symptomatic bradyarrhythmia. It increases the heart rate. Same side effects, tachyarrhythmias, MI, hypertension. Hypotension I told you because it doesn't have any effect on alpha. By beta 2 effects, it can cause vasodilatation in the skeletal muscles and can decrease the blood pressure also. So if patient is in hypotension and you have to use inotrope, you have to use very carefully if you want to use dobutamine. Rather, first we increase the BP and then start dobutamine for its positive effect. Okay, then the last two, isoproterenol, this is predom beta effect, beta 1 and beta 2, and phenylepinephrine predom alpha 1 effect. Isoproterenol, predom beta effect, mostly used as Pharmacological pacing for bradyarrhythmia in denervated heart. It's pharmacological pacing. Arrhythmia, MI, hypertension. Same side effects can be seen. Phenylephrine for alpha-1, pure alpha-1 agonist. No action on beta-1, beta-2 or dopamine receptors, used in hypotension with tachycardia. It can cause reflex bradycardia, hypertension, peripheral and visceral vasoconstriction and tissue necrosis, right? So keep these in mind when you are using the inotropes. Now, it's very important to know the dose, to know the effect on the alpha and beta receptor of these inotropes for using them, and be aware of their side effects, because there is a very delicate, you have to very delicately balance between their effect and the side effects, right? Effects can become side effect very quickly. So very delicately we have to give these drugs. Okay, I hope it has become clear to you. Thank you.